All right.
This is Russ. I'm going to let him introduce himself and tell about his background.
Good morning. Hi, my name's Russ Kruger. Been a respiratory therapist for about 44 years. Tell by the gray hair around. I started RT school in 1972, so I go back to MA1, the Bird Mark 7, PR2, and I think I started RT school when I was about 25. Okay, so how many people in here are 25 or older? Yeah. Hey, well, good. So kind of like in the same position I was in when I decided to go into healthcare. Why did I decide to do this? Why did I decide to become a paramedic?
Stay in the healthcare field, to be more hands-on.
Okay, are you already, anybody in RT in here? That's too bad. I wish more RTs would become paramedics. I wish I would have done the same thing. Okay. Any nurses in here? All right, great. Okay. So your goal is maybe to do flight?
No, I work for Bondurant. I'm the EMS coordinator for Bondurant.
Okay, great. Yourself?
I work in the ER.
Okay. Well, great.
She also works on an ambulance.
On an ambulance as well. Okay. And the rest are EMTs or paramedics? Okay, great. Okay. So the plan today is to kind of go through ventilation. Okay. Discuss types of different ventilators, what to be looking for. Then we will, and I'm going to bring up some slides kind of talking about the ARDSNet protocol and PEEP, because those are things that are going to be really important to you guys and following that, and then a slide in regards to why that PEEP is important. And we'll talk about driving pressure. Okay, it's kind of common talk today. You guys hearing that, unless you're already hearing that in some of your conferences that you go to, they talk about driving pressure, but we'll discuss it a little bit more. We'll also, I have a couple different ventilators here. So I'll do a PowerPoint on this ventilator. And so it's a PowerPoint that I would use, like I just used it for North and North. They're making a ventilator decision, kind of went to the ventilator. But we'll talk about, okay, so what are some features about that and how that's going to help you? And you can ask questions, how would I use this? Okay, we'll talk about alarms, we're going to talk about modes. Okay, and then I have two of them here, and we'll break up into two different groups, and you can play with them. Okay, and I have some masks. So if somebody wants to do non-invasive ventilation, we'll talk about non-invasive ventilation. You may be doing that already, but we'll talk about it with the ventilator, and then you guys can play with it. So feel free to ask me questions anytime. I'll try to explain it to the best of my ability. So, you know, roll up your sleeves and let's get involved. Talk about your experiences, and we'll go from there. There's no right or wrong question. Okay. So, you know, some commonalities about ventilators. I think I'm going to go back. Yeah. Okay. So if we're going to put ventilators into characteristics, they're all going to have a power source of some type. So it may be electrical, it may be battery, okay, and then blower driven, or it may be pneumatic, kind of like what you guys have. So the power source is the supply, okay? So they can be as simple or advanced, and so you'll come across those. Cycling, so basically there's going to be a trigger. So the patient's going to take in an inspiratory effort, and then that ventilator needs to cycle off. Okay, so there will be some cycling criteria. And then either breath delivery will be either positive or negative. So anybody know of a negative ventilator? Kind of an old ventilator. What's that?
Iron lung.
Iron lung, exactly. Iron lung or Coras. Iron lung, there's still a few of them out there. I work for the company Respironics. They bought a company called Life Care, and they were the ones that built all the iron ones, like Emerson, okay? And then there was a chest caress, kind of like a shell. Somebody looks like a turtle. It's got this thing that sounds like a vacuum cleaner. And so it would draws up on the diaphragm and then releases and lets the patient passively exhale, okay? So the hardest thing is getting that shell to fit for the patient. These are, what you have here is all be positive, and that would be the most common type of ventilator. Okay. So you're going to have patients that are going to have all kinds of, so if we look at common modes of ventilation, we're going to be looking at modes. So it's going to be a tidal volume, a rate, flow, FiO2, positive end expiratory pressure, or PEEP, okay? So you're going to be making those decisions. You're going to have a circuit. So here you have a circuit. Okay, and it has an it's got an external valve, okay? Basically, it's a balloon, pressure's applied to that balloon, so it helps the patient inflate their lungs, and then it releases so the patient can exhale. Okay. There be as the ventilators get more sophisticated, they're going to be a dual vent circuit. This is an infant circuit, okay? It's got a flow sensor here. That's what our ventilator uses. It measures everything at the airway. Other ventilators measure things back at the ventilator. Okay. If we look at this type of circuit here, this is a dual end circuit as well. That's coaxial. Okay. So you see this light blue thing? That's where inspiration goes to the patient, expiration goes along. Okay. Like I said, if you don't have a flow sensor, you need to take into consideration compressible gas loss from the circuit, okay? Because that is going to decrease the patient's volume that's being delivered. Why do you think that is? So when we add pressure, what's going to happen to this circuit? It's going to expand, exactly right. So if you look on a package of your circuit, it's going to say how much volume, okay, is lost or expanded, okay, for pressure of water. Okay? So you need to take that in consideration when you're ventilating something, okay, because you could be under-ventilating something. All right? So just some things to be thinking about, okay? And then our alarms, there's going to be various types of alarms. There's going to be a high and low pressure alarm. There's going to be minute ventilation. There's going to be in your system here, you have a relief pressure alarm. So when you're kind of a pop-up, okay, looks like it's set at 40. So if your patient coughs, okay, it's going to dump all that excessive pressure above 40 centimeters of water pressure. Okay, now we'll talk about it a little bit later. There's going to be a thing called pressure limitation. Going to let you know that, hey, maybe my patient needs to be suctioned, or maybe they're starting to develop some reactive airway disease. Which, you ever pick anybody up from a burning building? Right, you're pulling them out. Okay, you're ventilating them. Okay, all of a sudden now they've inhaled all those gases and hot air. Okay, they could be starting to develop acute lung injury. Okay, so they're compliance. Have you guys talked about compliance and resistance yet? A little bit. Okay, resistance is just think of a garden hose. Okay, you're running water through it. So if you have a small hose, you've got a high resistance thing. Okay, if you got a bigger hose, okay, you can get more water through it. Okay, so that's resistance, airway resistance. So think of your airway asthma patient. They're starting to their airways are starting to collapse, right? Bronchospasming, so they're going to have a high resistance. Compliance, a COPD patient has lost the elasticity of their lungs, so their compliance is very high, very compliant lung. Problem that they have is exhaling and getting all the air out, so we need expiratory time. Okay, somebody with a low resistance is somebody that's could be starting to develop acute lung injury. Maybe somebody you pulled out of picked up from a burning fire, okay, or somebody inhaled some bad gases, or maybe they just got sick and haven't been going to the hospital and procrastinated on going and already they're tough, okay? But devices measure that automatically now, so you can get more and more sophisticated. So you're going to be able to set your alarms, and there's all kinds of indicators for what's going on. Okay, so if we look at normal ventilation, we're kind of talking about this already. Here we have where the vacuum cleaner draws down. Basically what happens, you take a breath, you use your muscles, okay, you increase your chest, your diaphragm drops, air flows in. The patient relaxes, air goes out. Okay? And then we have positive pressure, okay? So what we're doing here is that we're blowing air in, we're forcing it in. Of course, there's some issues there. Also, now we have resistance because we're driving this air through the tubes and the trachea of the lung, or the bronchioles, and then the patient passively exhales. So like we said earlier, we talked about there's various forms of ventilators, pressure ventilators. That's what you have here. Okay, so you're setting a volume. I'm sorry, you're saying, but there are some ventilators that are pressure. Pressure ventilator would be like a manual resuscitator. Okay, you're generating pressure, you're delivering volume. Okay, volume ventilators, you're going to set the actual tidal volume to the ventilator. Flow cycled is like a BiPAP system. Anybody here have sleep apnea? Sleep with a BiPAP? Okay. Maybe when you turn 45 or 50, that'll happen to you guys. Okay. All right. Anybody snoring here badly? Okay. So if you have BiPAP, basic flows are flow cycle ventilators. So they go in, they hit a certain flow, and they cycle off. And then there's time cycle where you set a time, how long that inspiration will be, and then how long the exhalation will be. And then, of course, non-invasive ventilation is going to be positive, and those are flow cycled and pressure cycled ventilators. So here are the parameters, all the way from tidal volume, respiratory rate, FiO2, or the percent of oxygen you're delivering, what the peak flow is, how fast you're delivering that flow to the patient. Inspiratory plateau pressure, okay? Plateau pressure, you're going to learn about basically when you're ventilating somebody, you're going to be able to do a plateau test on more of the sophisticated. That plateau pressure is what that pressure is once we've eliminated all the dynamics of airflow going into the lung, okay? And that's going to really be important when we start talking about driving pressure. And driving pressure is the plateau pressure minus the peak. Okay. And what you want that driving pressure to ideally be is between 10 to 14 centimeters of water pressure. What that does is increase mortality to about by 80%.
Increases?
What's that?
Increases
mortality. Yeah. Okay. So if you're managing that, okay. So we'll talk a little bit later about setting peak appropriately with some guidelines to help you do that. That's something you can measure. So it's a matter of looking at your plateau pressure minus your PEEP is your driving pressure. And you want that in the 10 to 14 centimeter range. Low pressure alarm. Okay, hey, for some reason my ventilators become disconnected, or maybe the cuffs, the leak, or there's the balloon's deflated in my cuff. Why am I not getting enough pressure to my patient? High pressure alarm, we already kind of talked about that. That's going to be, it's going to dump the excessive pressure that you have, okay? And then here's another battery failure or low pressure source alarm. So there'll be various alarm settings, okay? Positive end expiratory pressure, or PEEP, okay? Occurs at the end of a mandatory machine breath, something that you set, okay? So we all have PEEP right now, okay? What creates that PEEP within us is our vocal cords, Okay, and that's about 3 and 4 centimeters of PEEP. If you have somebody that is obese, okay, you ever see that guy there? We were on vacation and we were at the pool and there was this guy. He would not sit back in his lawn chair. He went and got a chair from the outdoor cafe and brought it over to the pool and sat there. But he was a big guy, okay? Large abdomen, you know. So just think about it. When he's laying back, all of a sudden he's got all this weight, okay? And it's pushing up his diaphragm. Can't breathe very well, okay? So and I was thinking, I wonder what PEEP he runs at. He probably runs at 15 centimeters of PEEP. Because what we're finding out now is that we ventilate patients in the hospital. They get in trouble, we ventilate them. We find out that we need like 18 or 22 centimeters of PEEP. They resolve some of his issues that's going on, and then they end up extubating about 15 centimeters. Okay. He probably sleeps with a CPAP system at home, probably at 10, 15 centimeters of PEEP. So he lives in that world. Okay, so something to be thinking about when you're observing somebody. So what PEEP is that? Okay. But there's contraindications for PEEP, okay? Untreated pneumothorax, okay? Bronchopleural splicula, so you need to know what's going on and maintain PEEP levels during transport. I think this is a good time to talk about that, so I'm going to see if I can minimize this. And hopefully we won't lose anything. Perfect. Okay. So this is the ARDSNet protocol. Okay. So it's all about maintaining a target SpO2. Okay. And remember, you got your pulse oximeter on in your rig, right? Okay. And an FiO2 less than 60%. The target tidal volume, 4 to 8 milliliters per kilogram of body weight, of ideal body weight. And then here it has keeping your plateau pressure less than 30 centimeters of water pressure. So plateau pressure is somebody's gonna, you give a breath and then all of a sudden you hold the ventilator to stop it. Things relax, your muscles relax, and now you're finding out what that plateau pressure is because you've taken out the airway resistance and driving airflow to the patient. Does that make sense? Okay. So then you're having your respiratory rate here, 10 to 16, and your PEEP. So what PEEP should you use? So you're going to use, you can look at your FiO2, okay, and your PEEP to maintain that target tidal volume, okay? So something to be thinking about. So if you're at 60 centimeters, 60% O2, and you're trying to keep your saturation here, you should probably be at 10 centimeters of PEEP. Okay. If you're using your FiO2 as higher, and you're not getting that, you need to be increasing your PEEP level. Okay, so something to think about. Okay, I see people now, even ambulance services, they're starting to take that, they're putting that strip here, going okay, or they have it on a sheet, it's laminated. This is what we need to be doing. When we bring out the ventilator and we can start doing a plateau pressure, okay. Okay, here's what I was talking about earlier of keeping your plateau or your driving pressure between 10 and 14. Our survival rate goes up significantly. So again, that is plateau pressure minus PEEP. We'll do a plateau pressure on these ventilators so you see what that's all about. One of the things that you're finding out is that transport ventilators are, I don't know how much, are you doing mostly rescue or are you doing transports? Mostly rescue? Both, okay. So you're finding people that start somebody on ventilation and then all of a sudden now they're doing nitric. You heard about that? Okay. So what that helps is to help heal the lung, okay, help those blood vessels deliver oxygenation. Okay, so you're finding out that you can do that a little bit more, especially with extremely hypoxic patients. You're trying to optimize these various therapies. They're a bridge to more advanced stuff. So maybe ECMO or something like that, or putting in esophageal pressure monitoring. So when you have somebody, you're only going to be making necessary adjustments that you need to, but you need to be figuring out what that target tidal volume is. Okay. Make sure you got adequate oxygenation and adequate minute ventilation. How are you going to know if you got an adequate minute ventilation? Are you monitoring CO2 by any chance? You are. Okay. So you're going to monitor CO2. You're going to be in that 35 to 45 rate, right? So you're going to adjust your tidal volume, your rate, and your minute ventilation. Okay. And always pre-check your ventilator. So you're going to choose between volume and pressure. When would you use volume versus pressure?
COPD patient as opposed to a person without COPD?
Sure. Okay, so the volume, you're going to target a tidal volume. Okay, if you're delivering too much pressure with that volume, maybe you want to switch to a pressure control ventilator because you can control the flow delivery maybe a little bit better. Okay, or maybe what you can do is you want to have more inspiratory time versus expiratory time. And you're not letting your patient exhale completely. So what you're doing is you're creating what's called auto peak. Okay, so you can, it's inverse IE ratio. You can, again, using a 6 to 8 milliliter predicted body weight, trying to figure out what mode of ventilation, and we're going to talk about that here in a little bit. Okay, auto PEEP and hyperinflation. Patients prone to auto PEEP are going to be people with asthma and COPD. Okay, so you're going to try to do is eliminate that auto PEEP. Usually when we were talking about trying to create some auto PEEP for people is when you have acute lung injury. You're not going to do that with COPD patients. You want to give them longer exhalation time so they can get all the way back, get out, all their air out, or an asthma patient as well. When you have auto PEEP, you're also going to want to administer some bronchodilators, okay, to help expand those airways, relax those airways so they can exhale. So if we look at the air trapping process, so here you can see that my patient's taking inspiration and then they exhale, and they're not getting all the way back to zero. So here's zero, taking inspiration. This here is volume. Taking in a breath, they're getting back. They don't get all the air out. Okay, so this is what air trapping is. This is what overdistension is. So here we're giving pressure, and then all of a sudden we're getting this bird beak like, and that's one thing you'll be able to see on ours. If you have a flow volume loop or a pressure volume loop, you're going to be able to see over distension. This bird beak you don't want. You want it to go up here and then they'll cycle down. Cycle down. This means that you're over distending. Okay, you're delivering too much volume to your patient. So during transport, you're going to monitor your patient. You're going to monitor peak pressure. Okay, we want to keep our peak pressure as low as possible, but you have to have some gas there to deliver, right? Okay, your respiratory rate, your exhaled tidal volume, you want to be measuring that. And you want your exhale tidal volume to be looking at probably in that 6 to 8 kilograms of milliliters per kilogram of body weight. Inspiratory-expiratory ratio. So ideally, you'd like your inspiratory time shorter than your expiratory time, or at least a 1-to-1. If we have longer inspiratory time than expiratory time, then we're going to have some auto PEEP and some airway trapping. We only want to do that maybe in a unique situation. And you're going to be documenting what you're seeing. Are you guys using your documentation? Are you doing anything like image trend or anything like that? Or are you manually documenting? Image. Okay. Okay. Okay, so what I'm going to do is go through our ventilator and show you some aspects of that. Any questions about what we just discussed? Okay, so this is a Hamilton T1. You can see it's pretty light and portable. We have some other ventilators that are used in a hospital. This goes into our MRI unit. This is intra-hospital transport. These are the two that I have here. This is our air and ground certified unit. This is intra-hospital. You interact with them exactly the same. This one's just built heavier duty for what kind of use you guys do. Okay. So if we look at how this thing drives, it's got a turbine, okay? So then we can deliver. So our peak flow of this is 260 liters per minute. That's important because you need to be able to meet the patient's inspiratory flow rate, especially if you're using higher levels of PEEP. We'll talk about that, okay? But also, if you're doing non-invasive ventilation and you have somebody, there's nobody in here with a beard.
Can't have them as far.
What's that?
Can't have them as far.
Oh, really? Oh, that makes sense. Okay, all right. But so if somebody, just think if somebody has a beard, okay, or you're picking somebody up, an elderly person that you take out their dentures, now they have no architecture to make a mask seal, okay? Or maybe they have an NG tube, you're transporting them from a nursing home to the hospital and they have an NG tube in. So how are you gonna get that mask seal? You're not gonna be able to get it perfect. So you're gonna have some type of leak. And sometimes that leak gets pretty big, up to about 60 liters a minute. So you need to be able to meet inspiratory flow needs of your patient plus leak compensate. Okay. And what's also important is that here we can leak compensate to 60 liters. There's also an algorithm that in the presence of a changing leak, it stays synchronous with your patient, okay? Because that leak is variable. That's going to be important. Being able to provide, we can provide up to 35 centimeters of PEEP. So this is basically a critical care ventilator. Okay. You know what PEEP level we can go up to here? What's that?
It probably is no PEEP right in the circuit.
Oh, that's right, because you adjust it, right? Okay, so how you're reading your PEEP is when you see where the needle comes down to your starting point, right? So you can tell if you got 15 or you got 5 or 10 or whatever. Is there a PEEP level that you normally use?
5 to 10.
5 to 10. So then this one also is driving, so it's got a battery. You can see what our battery time, if you have one battery, it's 4.5 hours, 2 batteries, 9 hours. And we can go down to neonates, down to 200 grams, 200 to 30 kilos, had a volume of 2 mils to 300 mils. And then adults, 20 mils, we'll go down to 3 kilos or 20 mils to 2,000, okay? So that's what's unique about that, and we'll be able to show that. This is just to give you some orientation to what the ventilator is going to look like when we turn it on. It's always going to show us what our active mode of ventilation is, and whether it's neonate or if it's adult pediatrics. Okay. Here's your main control. It's going to be right here. So here's your respiratory pressure. Here's your PEEP, CPAP. Here's your FiO2. So we can go from 21 to 100% O2. There'll be more modes. Here's your pressure waveform. You can have a flow waveform here. And then here is your most common monitor parameters. Peak pressure, frequency, exhale tidal volume, minute ventilation. Now we'll be able to show you that we'll be able to go into more monitoring. So there'll be like 24 different monitored parameters. Okay, you're going to be able to see auto peak. You're going to be able to see your plateau pressure. Okay, that type of thing. Fact is, out of those, you can display them here. So if there's something, hey, I always like, we're working with Vera McKinnon Hospital for their flight team. They want to display plateau pressure here. Okay, it'll show up. So then they can monitor driving pressure. So they'll look at their PEEP, what they got it set at, minus their plateau pressure. They know what they need to do. So this is kind of the front panel up here. It's always going to tell you what's going on. So here it says battery low. Okay, we're going to display our battery. There's some functional keys here. It's got this handle up here. You can hook it on. Okay. Here is where our exhalation valve is, and that's right here. So this is internal active exhalation valve. This means that it's magnetic, and it pulls on this membrane. You look here, it's sealing this point here, okay? It's working similar like that, only it's using a magnetic electronically, okay? And so then it floats. So then it's very comfortable for your patient to breathe by phasing, okay? A lot of the paramedics like this because they're finding out that they're using less sedation, okay, because their patients are breathing so comfortably. So if you want to take a look at that, pass that around. You're going to see here's our exhalation. Here's where this goes to the patient, where flow comes in, right here. It's going to go to the patient. It's going to come back and then exhale. So there's no exhale gas goes into the ventilator. This is where we can have a nebulizer right here. So we can hook up a nebulizer, tee it in line, so you can nebulize some medications. Okay? So there'll be a button. You have your medication in there. You push a button, starts nebulizing. And then this is where your flow sensor is. So we're monitoring the airway. This is kind of the setup, what it looks like. Here you have a dual in circuit. If you want to have a heat moisture exchanger. On here, we've got inline suction. You guys have that? Use inline suction? No? Okay. Heat moisture exchanger. HME. You just dry gas right to the patient. Okay. So how HME works is that it delivers a breath to the patient. Patient exhale. The patient's lungs is full of humidity. Okay. So the heat moisture exchanger collects that humidity, and then when you give a breath back to the patient, you're giving them back their humidity. Okay. So there's all kinds of them. The biggest thing is find one that's low resistance. Okay, because there's various ones, various sizes. So here's your HME, here's your flow sensor. So we're monitoring at the airway, so we don't have to worry about compressible gas loss from our circuit. It's right here, very quick, very sensitive. Okay, we just kind of talked about the exhalation valve already. Battery, so let you know when you're plugged in and your battery's charging. It'll be charging. It'll charge even when you're on the patient, or if it's just idle, getting ready to go. Let you know what battery you're on. This, if you have two batteries in here, display two batteries. Let you know if you're into if you're plugged into AC power, they'll let you know what battery you're using. It usually uses the hot swappable battery first. So there's a hot swappable battery here. You pull it out. Okay, put in another one. We'll use this one first. Most people that I know of don't need an extra battery or hot swapping because most of their transports aren't longer than about 4.5 hours. So it's going to be easy to use. So you're going to have your silence button will be right here, 2-minute silence, and it'll display how long your 2-minute silence is, where it's ticking down. Here's going to be your control knob. Okay, so it's going to be identify, adjust, accept. The power button is going to also be your turn it on, standby, and then also to shut it off. And then we can print the screen. So you can put a thumb drive in here. When I came down here today, this ventilator was different than this one, the way it was set up. So what I did was, I like the way that one was better, took a thumb drive, put it in there, exported the settings, put it in here, and cloned this one, so not just that way. So there's a transport team up in, it's called Lakes Region. They have 10 ambulance services. So they want all their ventilators to be same, so we just went and cloned them, okay? The other thing is, if they're having, they're seeing something kind of odd, or there's a teaching moment, they have an educator on their team, and they get some screenshots. They'll take some screenshots from them, get their group together, and talk about how they could have managed differently. Or if they're seeing something kind of odd, we send it to our clinical team. Our clinical team kind of looks at the waveforms and kind of gets back what we thought was going on. O2 enrichment. So we can do 100% O2 button. So just by pushing this button here, 100% O2, it'll deliver that for 2 minutes. Little clock will tick down, let you know where you are in that 2 minutes. Also, remember I was talking about plateau pressure? We can do that with this little set of lungs. Okay? So especially when your patient's sedated and controlled, you can do that. You're doing volume ventilation. You just hold that button for 3 seconds. You let up. You hit the scroll button. You scroll over. And now you can see what your plateau pressure is. Okay? And then we can get, so it's also for giving a manual breath. We can lock the screen. So we can lock the screen if it was ventilating. Yeah, okay, so it's locked. Okay, unlock it. Really important when you're transporting somebody so it doesn't get bumps. It's still going to let you do 100%. Start the nebulizer, all that type of thing. Okay, and like I said, there's a nebulizer, atomizer here, picture. It's going to nebulize, okay? It'll nebulize on inspiration only for 30 minutes. Okay, so when you first bring up the ventilator, it's going to come into standby. So give you an orientation so you can use this to show this here. We also have 3 hotkeys. So we can customize those to be what you want. We'll talk about the various modes here shortly. Your ESVs are closed loop mode, non-invasive mode. Somebody had a CPR mode. Okay, you put in male or female, their height, and it'll give you ideal body weight. Okay, so now you can know what tidal volume you should be working with. And there's also a pre-op test. So pre-as use, there will be a tightness. You're going to put your circuit on. You'll do a tightness test. Goes up to 45 centimeters of water pressure. Make sure you got a tight system. And then you'll do the flow sensor test, and you're matching your ventilator to the flow sensor. Okay. This is the flow sensor. So at the airway, we're measuring pressure, flow, and volume. So everything is done right there. We have a last patient. So let's say you transport your patient, you stop off somewheres, and then you need to restart them. You can restart them. Or you got a new patient, you're going to hit adult pediatric patient will be. mode screen, okay? So you're gonna have every possible mode that's available to you. So here you can see it, here's the modes, okay? So let me show you one thing here quick. Okay, so we live in a free enterprise system, okay? So every vent company, whether you work here, use the Parapack, or you go somewhere else and you use Care Fusion, Revell ventilator, or somewhere you have it. Every company has their own terminology for the same modes. Okay? And that's because who the engineer was or the scientist who invented that mode gets royalties on it. Okay? So that's why APRV is basically a, trying to think, Dr. Downs created APRV. He gets a royalty for every ventilator that we do. Okay? So if you go bi-level is a Pearson Bennett mode, or I'm sorry, a Draper mode. Okay, so they invented that, and they used the term IPAP. Okay, IPAP was a Respironics term. They bought the rights to IPAP, but they put it instead of or BiPAP. So instead of being B small I capital B capital A capital P, they did capital B capital I. Okay, so that's their BiPAP. Okay, so it's very confusing. But so you can see, so here, of course, Hamilton, we're going to use APV, and we say CMV. That's going to be like assist control ventilation. Okay, so what are the SIMV? So you're going to see CMV. So you're going to see all those. Okay, so you just need to be aware of it. But you have to figure out with your ventilator how that ventilator functions. Okay, how it gets to what is the terminology. Okay. So, why can't we keep it simple? Well, that's kind of why. Okay. Okay. So, what are we going to see here? So, APV, adaptive pressure ventilation, okay, is a volume targeting mode or continuous mechanical ventilation. So, we're going to dial in a tidal volume. Okay, it's going to target that tidal volume, and then we're going to vary the pressure to keep targeting that tidal volume. Okay, so as compliance and resistance changes, we'll adapt to that to maintain that same volume. So if my compliance is decreasing or my airway resistance is increasing, and I want to target that same tidal volume, what's going to happen to my pressure? Go up, right? Okay. So, but then let's say all of a sudden my compliance starts to fall and my patient starts to spontaneously breathe. What's going to happen to the pressure? It's going to start going down, right? So you have to be aware of that. Okay. So.
That'll do that automatically. You don't have to keep adjusting it every time.
Well, I'll get into another mode that we do that. And then there's APV, which with SIV, synchronized intermittent mandatory ventilation, kind of a mode used in the hospital. So basically, anybody